name is Sheena Lillis, and I will be discussing the anatomy of the hand. First, we're going to go over the MCP, the PIP, and the DIP. So this is the MCP, which is the metacarpal phalangeal joint, the PIP, the interphalangeal joint, and the DIP, the distal interphalangeal joint. The volar plates are on the palmar surface of each joint and help support and prevent hyperextension. The flexor digitorum profundus comes up through the carpal tunnel and inserts on the distal distal phalanx. So to test, manual muscle test this hand, you will put the client's hand flat on a surface. You're going to hold down all of the rest of the structures of the hand and allow the DIP to flex. Test the full range of motion first. Then you're going to give a little resistance. Of course, I can't do it on my own hand, but you're going to give it a little resistance as they come up to the mid-range, and then test the exact strength. Remember, when you bring that distal phalanx up, full range of motion is a 3. Okay. So then we're going to go over the sagittal bands, and these help support the MCP, and it goes all around that joint. So then we're going to flip onto the dorsal side, and the extensor digitorum communis comes up, and it kind of blends in with the central slip. So it comes to the middle phalanx, the central slip, next, we're going to go over the lateral bands. And so that comes a little bit proximal to the PIP joint, and then inserts at the terminal tendon insertion. And this is on both sides. And then the conjoined lateral bands help attach the central insertion or the central slip to the lateral bands as well, giving extra support. And that surrounds the PIP joint, giving stability there. Next, the lumbricals. They come off of the flexor digitorum profundus. They cross the MCP and then go dorsally. So it comes MCP here and then dorsally to the lateral bands. And because they attach into the lateral bands, they're going to help create that PIP and DIP extension. So the lumbrical motion will be MCP flexion because it comes after the MCP, and flexion or extension at the DIP and the PIP. So this motion occurs with the lumbricals. Okay. Next we have the first dorsal interossei, so that attaches from the metacarpal and attaches also into the lateral bands. And this helps to create abduction at the finger, but it also, of course, will do extension and abduction because it is going into the lateral bands. Right, and then we have the transverse and the oblique fibers, and they essentially help attach that dorsal apparatus, giving support and structure to this region, and it goes all the way up to the central slip. Okay. So with mallet finger, if the terminal tendon ends up rupturing, that finger, or that distal phalanx, will come into flexion because of the flexor digitorum profundus. So passively, we'll be able to go into extension, but the mallet finger often looks like extension at the PIP and a flexion, almost like a mallet form. So the mallet finger deformity. All right. With boutonniere deformity, the central slip ruptures, and the PIP kind of slips through that central slip, creating flexion at the PIP, but because the terminal tendon is still intact, that DIP is going to hyperextend because of the tension, increased tension from the flexion at the PIP into the DIP. So boutonniere deformity often looks like that. Oh, I'm sorry, for mallet finger, this is going to happen in extensor injury zone 1 on the extensor side. And then with boutonniere deformity, it happens in flexor extensor injury zone 3. Okay. So with swan neck deformity, the opposite happens, and the lateral bands slip dorsally, okay, and can also cause them to retract slightly, creating hyperextension at the PIP. Oftentimes the volar plate will rupture, creating even more hyperextension. And because of the pressure from the flexor digitorum profundus, that distal phalanx will go into flexion. So you're going to see hyperextension at the PIP and flexion at the DIP. And this often happens with progression of mallet deformity. Okay. So next we're going to go over the CMC of the thumb. So the CMC is a saddle joint at the base of the first ray between the metacarpal and the trapezium. The MCP is here and the IP is here. As you can see, there's no DIP. There's only the two phalanx here. All right. Next, with the thenar eminence, we have the flexor pollicis brevis, the abductor pollicis brevis, and the opponens pollicis. With the hypothenar, which is on the ulnar side, you're going to see the abductor digiti minimi, the flexor digiti minimi, and the opponens digiti minimi. The adductor pollicis is a pretty deep muscle. I'm going to just go ahead and do that in black. And that attaches at the capitate and the base of the second and third metacarpal. And it moves through, attaches at the proximal phalanx of the thumb, and then it goes to the dorsal expansion hood. And that's a deep muscle creating a deduction of the thumb. We discussed the lumbricals earlier. The lumbricals are on the radial side. Remember, they go dorsally and they attach from the digitorum, flexor digitorum profundus. And there'll be 4 of those to create that MCP flexion, the DIP, and the PIP extension. And then we have the palmar and dorsal interossi. So the palmar interossi create a deduction. So there's not going to be one on that third phalanx. and there's 3 that create that adduction. Okay, now on the dorsal side, we already discussed how it creates abduction. Well, that middle third, the third finger or the third digit cannot adduct, but it can abduct each way. Okay. So there are 4 on the dorsal side. And that creates, remember palmar, adduction, dorsal, abduction. All right.